involved in most of the major clinical trials in the world on the adult side and the pediatric side. And so I consult with the companies that are doing the clinical trials. And I'm a principal investigator in most of the trials. So I will actually talk about those medications later on, because they're really critical to where the field is going in the future. Okay, so a lot of what I'm going to talk about today is actually philosophy. It's kind of how do you think about things, or at least my take on why we should think a certain way about how we manage children and adults. Truthfully, a lot of our advances in the field come from the pediatric side, and then they get applied to the adult side. But I have the luxury of working in both worlds, and so I can take stuff from peds, adapt it to adults, and then take stuff from adults and adapt it back to pediatrics. And you'll hear towards the end how some of the adult stuff is moving back into peds, and I think changing the way I'm thinking about managing things. But here's what I think is sort of the overriding philosophy of our entire program. You know, we have a pretty big program, one of the biggest programs in the world, looking after children and adults with intestinal failure. And I'm speaking today specifically about the non-transplant stuff. I do transplants, but that's a relatively minor part of everything that we do. It's probably a few % of all of the patients compared to the vast majority who are going through rehabilitation. And so honestly, I think you have to have almost like a mission statement for how you do things. And for our program, this is it. It's really, if you're not going forwards, you're going backwards, which means you should always be making progress. There should be something that you're working on with your team. Just, it doesn't have to be a major thing. It doesn't have to be, oh, we're coming off of TPN this month. It can be, oh, I want to have a little less bowel movements, or I want to have a few more hours off of TPN, or some freedom to do something this weekend that I don't normally do. But there should always be something that's helping you to advance forward. If you're not doing that, I guess I would argue you're kind of just treading water, and you're not doing what you need to be doing. So this is a great big figure I made for a book chapter, I think. And we're not going to go through all of it, but I just want to point out one key thing. So if something happens, whether it's in infancy, you know, or a little later in childhood, or even in adulthood, something happens when you lose some of the intestine, you lose your ability to absorb, so loss of some absorptive surface. What do you do? Well, the first thing you do is you just have to let the dust settle, right? So this is for those of you that might be parents here that have little ones who were in the NICU or may still be in the NICU. You know, this is that first few, just those emotionally turbulent, difficult, hard weeks where stuff is happening. Your child's in and out of the operating room. You know, you start learning about all of this stuff for the first time in your life, whereas maybe you've never even thought about intestines before, nutrition before, and people come talking to you about all kinds of stuff you've never heard about. Initially, you just want to stabilize, get things settled down, and then sort of look at what happened. How much bowel did you really lose? And you know, there's lots of different things that can happen, but if it really wasn't so bad and the team there is pretty happy, there's plenty of intestine, well, then you're probably okay. But if it's anything more than that, you really need to be, and when I say you, I mean you and your center. So not necessarily you specifically as a parent, but someone needs to be in touch with a specialized center. Now that doesn't mean you have to immediately, you know, jump in a plane and transfer to Nebraska or transfer to one of the other major programs in the country. But somebody should be talking to one of the major specialized programs and sort of saying, hey, here's what we're dealing with. Do you think we're on the right track? What are some things that we should do? Because if I could do nothing else other than get the whole country to talk to a specialized, a 10-minute phone call with one of the, you know, top 10 centers or something, we would save a ton of lives and a ton of problems later in life, because we often are forced with getting kids later on where we have to correct a lot of things that could have been avoided in those first couple of weeks. I wonder if there's maybe somebody who could mute their microphone, because I don't think that's on my end. Thank you. Okay, so what's one of the really important surgical principles? Putting everything back together early. So what does that mean? Well, if something catastrophic has happened, often at the first surgery or the first few surgeries, we as surgeons might be kind of doing damage control, removing very sick bits, leaving in some stuff that may or may not be alive, and deciding what to do, perhaps going back to the operating room every day or every few days. And so sometimes you can be left in a situation where you're, you know, what we say is in discontinuity. Maybe you have an ostomy very high up in the bowel, or the bowel is not put all together again. And sometimes what you'll face is, maybe a surgical team that says, oh, well, we really can't do any surgery for 6 months or for 12 months. And during that time, it's a high ostomy and we can't get hooked back up again. And we really don't want to eat or drink anything. And I'm really sort of opposed to that approach. I think that we want to get all of the bowel back working as early as possible. And in almost every circumstance, and there are very rare circumstances where you can't do this, but you can almost always get all of the bowel back together again. And you'll hear people saying, oh, well, there's going to be so many bowel movements that if we hook up this short segment of intestine to the colon, it's just going to be endless pooping. And that's just simply not the case. We do it all the time and we have really good outcomes, and so would you. So I think you want to get stuff back together early, as soon as that's safe for me. And when I'm counseling people, I say, look, 6 weeks, 8 weeks is about all you need for almost every abdomen. Now, there are individual circumstances. As a surgeon, occasionally you're in a circumstance where you say, gee, there's some special thing that means I need to wait for 3 months or something until I can get back in there. But there's very, very few instances where stuff can't be corrected within 3 months. This idea that people have to have an ostomy until they're a year old or something is just a year where you're losing ground, a year when you're not stimulating eating, a year when all these things that could be happening aren't happening. So I really think you want to get everything back together. I think you want to use as much of the intestine as you can. And this is true for adults and children, but there has to be a little thought about it, because in some instances, there's some bowel that may be very marginal. It's got kind of poor function. Maybe it's very narrowed, very, very stretched up. And there's times when you sort of say, well, gosh, if this little one has 40 centimeters of really good looking intestine, but then 7 centimeters of really crappy looking intestine, do I want to keep 47 centimeters, or would I rather just have 40 of good stuff? And I'll tell you, having done this an awful lot, I'd rather just have 40 of good bowel than 50 where 10 of it isn't good, because that's going to end up being an Achilles heel. So sometimes you do have to get rid of some bowel. Now that can be really scary if you're a parent and someone's saying to you, well, gee, your child has short bowel, but I need to remove a little bit of it. But that's the rationale behind it. It's saying what you want is good stuff. You don't always want to have everything, because sometimes everything isn't the right answer. And I did tell you guys that in general, I'm a big fan of restoring continuity, of getting everything put back together, which basically means you're hooked up from mouth to bottom end, you're pooping. There are occasional times when having an ostomy is the best option, though. Really, I tend to see it truthfully more in adults than in children. But if you're an adult and you have very, very short bowel and really very short colon also, sometimes in the desire to avoid an ostomy, a patient might say, oh gosh, I can't bear the thought of having to have a bag on the outside. Can you please hook me up? But the problem is, if you do it in certain circumstances, suddenly you're pooping 20 or 25 times a day. And now you get in a circumstance where you can't leave the house. You can't run to the grocery store. You can't go out for dinner or can't go visit a friend because you're afraid you're going to have an accident. So there are instances when you want to have an ostomy. For most kids, this isn't the case, but there are some instances, and I would be foolish to say never in medicine, because there are instances when it's the right thing to do. But it requires some thought, and it requires an experienced surgeon. And as a parent or an advocate for your patient, or adults who might be listening to this, you sort of want to have a surgeon that you feel comfortable with, who you can sit down and have a very frank conversation, who you can look in the eye and they look you back in the eye. And at the end of that meeting, you're like, yeah, this person, has really got my best interest at heart. I think if you have that feeling and you understand what's going on, that can help you a lot when you have to start entertaining challenging operations. Okay, so I'm a surgeon, and I've been talking about, when we should do surgery and, saying we should do surgery earlier rather than later. But I honestly believe you should probably try everything else before you jump into surgery. And this is just a good rule of life. Forget about short bowel. This is just like a good rule of life in general. Or, it's just, if you can do something else to not have to have surgery, that's probably a good idea. And again, this is coming to you from a surgeon. So what do you do? Well, in peds, we think about different formulas. We think about changing the feeding pattern. So if you've been doing continuous feeds, maybe you need to do bolus feeds. Maybe you should be doing oral feeds, doing some combination of both, where you're doing drip feeds at night, boluses during the day, or vice versa. You may have to do things to try to speed the bowel up. So these are called pro-motility agents. You may have to do things to slow the bowel down. So anti-motility agents. You may need antibiotics in some cases, although I will tell you, as a general rule, I would say if you're needing continuous antibiotics, or people are saying, oh, I've got SIBO, small intestinal bacterial overgrowth, and I have SIBO all the time and I have to be on antibiotics. Well, that should make you probably pause and say, what's the cause for that? Because that doesn't just happen for no reason. That happens because there's an underlying change that causes that to occur. So if you're needing to be on continuous antibiotics, it at least merits a conversation to say, okay, why is this? Because we shouldn't really need continuous antibiotics, and we tend to not use them in our program, although we will use them here and there. And occasionally we might try probiotics. It's kind of up in the air as to whether probiotics really make a difference. There's kind of some evidence in short bowel patients to say that the standard doses that we use don't really change the microbiome at all, but we do it sometimes, and I think it's a fair enough thing. But sometimes the best of teens, the best of parents, the best of kids get stuck. You just get jammed up, and so you have to think, okay, now what do we do? Well, this is where surgery comes in. So in general, we're going to face two major scenarios in surgery. We're going to face obstruction, so something is blocking things from moving forwards through the intestine, or we're going to face dilation. Obstruction, believe it or not, is, in the grand scheme of all of the patients that have short bowel, it's a relatively rare thing. Why is that? People hear about, say, obstructions from adhesions. Well, if adhesions are going to cause obstruction, in general, there has to be a little bit of freedom for the bowel to move around. And for children, I'll tell you, most short bowel kids, things are kind of stuck on the inside. So there isn't a lot of freedom for things to twist around adhesions and stuff. So they tend not to get obstructed very often, surprisingly. Adults can be a little different. If you're that adult who's had perhaps Crohn's disease and you've had 15 or 16 operations in the course of your life, well, sure, sometimes that is what's going to happen. You'll be dealing with intermittent obstructions. Now, dilation is something that we see not uncommonly in kids. So this is the circumstance where maybe your team has told you, oh, there's this one part of the bowel that looks like it's kind of stretched up, but we're not quite sure what to do about it. This is where judgment and experience really comes into play. So I think you want to have looked at a lot of children like this and looked at a lot of films. And it's also good to have one radiologist who does most of the tests. Now, as patients, you may not necessarily know who the radiologist is, but the team should have some idea of that. So in Nebraska, we try to concentrate all of that experience with one radiologist, just to make sure that they understand what we're looking for and they understand the subtleties of what we're trying to decide. Okay, just a little more segue into philosophy for a while. So Darwin sort of told us that, we have adaptability is what prompts, that drives us towards survival, right? That if we can adapt to a circumstance, that we have a tendency to survive, and we sort of send those genes down the line, and that leads to evolution of our species. And so short bowel syndrome is fascinating to think in these sort of philosophical evolutionary terms, because if you really think about this dispassionately, if you think back to caveman days or the Dark Ages or medieval times or something, the reality is anybody who had short bowel syndrome didn't survive, right? If you were a caveman and you had some catastrophic event, or as a child you had some catastrophic event, that was just the end of things. And so there wasn't a way to, sort of develop a way to adapt to short bowel syndrome. And yet we sort of do. So we know that children and adults seem to adapt to having short bowel. And I always find this very interesting, because somehow we must be borrowing some mechanism that was developed for our bodies to do something different. And yet it's helping us to achieve this outcome, because we have crazy good outcomes now in managing really, really short kids and really, really short adults. One of the things that can happen is dilation, like we were talking about. And people sometimes talk about that as being an adaptation to short bowel syndrome. But it really isn't adaptive. It doesn't help us to do better. It actually makes us worse. So when you dilate, that piece of bowel wants to, if any of you have my video on, that piece of bowel, maybe it should be this size, it should be this tiny little circle, and instead it's this great big thing, and it's trying to squeeze, but all it's kind of doing is waving on the edges. And so the stuff inside is sloshing back and forth, and it fills up and fills up and fills up, and you feel all bloated. The child, your kid, looks like they do well for a day or a couple of days, but they're sort of filling up on the inside. Then suddenly they projectile vomit on the second day or the third day, or they have a sudden rush of bowel movements. They'll have 8 poops in a row, blow out diapers, and poop all up the back of the car seat and destroy the crib, and you're up all night, that sort of thing. So dilation isn't making things better, it's making it more challenging. But what can we do? Well, we have some techniques now where we can sort of say, okay, if something's happened that isn't optimal, what can we do to make it better and maybe even take advantage of it to improve our circumstances? And that's where we come into the idea of enteroplasties. And that's what I'm going to talk about next. So entero, the prefix entero means intestine or guts, and plasty means to change, like plastic surgery, plasty. So enteroplasty is just a fancy word for change the gut. It makes us sound smarter when we sort of use Latin derived words. What's the point in all of this? Well, think about dilated bowel as being this first picture. If you have a big old dilated tube and you've got all of your enteric stream, so that's the food, the digestive juice, and everything else going through this big dilated pipe, most of what's inside that pipe isn't touching the sides of the pipe. It's shooting through the pipe and it's coming out. And so you can see in the picture, that's pouring out like diarrhea. What we want to do is we want to take that big dilated pipe and we want to make it into a smaller pipe. Why? Because then a much higher percentage of what's on the inside is touching the sides of the pipe, and that's what we need to absorb. So when we do these operations, and sometimes we'll talk about these as lengthening procedures. So parents will come to me and they'll say, can we do the step procedure? I hope that we can do a step so that we can lengthen my child's intestine. And the challenge here is we're not really trying to create length. What we're trying to do is reduce diameter. And this seems like splitting hairs, but it's really important. We're trying to get the bowel down to a normal size. Now, in some of the procedures, by doing that, the bowel sort of gets a little bit longer, but it's not that we're magically creating length, because that bowel still tends to behave like what its original length was. So sometimes people will think that, oh, doing a step is a desirable thing. That's what we should shoot for. And, we've done the most, I've done the most of this operation in the world. And the point isn't to make the bowel longer, it's to make it more narrower. And if it gets a little longer, that's kind of a side effect, but it is an easy way to explain what the procedure is all about. This is what a step procedure is. It's taking this big old tube and then doing a series of firings back and forth in a zigzag fashion to sort of effectively reduce the diameter of the lumen. And I have a little video here I'm going to show you. Hopefully it projects okay. Let's go here. Oh, that looks great. And you can sort of ignore my voice in the background, but this was a girl, we were operating on her when she was about 12 years old. Maybe she was 11 at the time. And this is big dilated bowel. Here I'm kind of flicking it with my hand and it's not really moving very much. That bowel should probably be about 2 centimeters. And there I'm measuring it and it's about 8 centimeters. That's about 4 times normal. I'm passing a catheter, a plain old Foley catheter through the bowel and looking for narrowed spots and suctioning out all of the air and the contents and stuff so I get that nice and flat. Okay, so once that's all decompressed, then I can take a stapling device. This fires really tiny staples, like a millimeter, like 1/16 of an inch kind of thing. Fires 3 rows of staples, and then a little blade cuts between them. So I'm lining that up and I fire the stapler. And you're going to see the bowel is going to open up like a V. You'll see it right now as I pop it off. Click, boom, and there's that V. So that's sealed on both sides, and we've sort of made a V that goes across the middle of the bowel. Now I make a teeny little hole with cautery on the other side, put a stapler in from the opposite direction, and do the same sort of thing. The fancy term for this is doing this mesenteric, antimesenteric. Mesenteric is the side where the blood vessels come, and antimesenteric is exactly opposite to that. So we're doing mesenteric, antimesenteric, this is kind of technical and dorky, but I just think it's a better way to do it. Having done a lot of these, it's an easier way to deal with in the future if you have to do re-ops and stuff. So here you can see I think we did about 28 firings here. And so now when I flick this bowel, you'll see little waves of peristalsis now moving around. I guess it kind of doesn't project there, my finger's pointing, because the bowel is squeezing and now it can push stuff forward. So, the end result of this case, honestly, was this girl, I think she was about 11 at the time, and she was on 100% TPN, and she's now 19 years old. She's off TPN, and just, if you saw her walk in the room, she just looks like a Hollywood model now. Like, she just looks so grown up. And she has a very normal quality of life. So you can go from 100% TPN and can't really eat anything without puking to being a normal kid working at Starbucks and going to college and stuff like that. Okay, so let me just show you a little bit of data about this, because we published a few papers on what we've done. So this is a paper we published a few years ago on our first series of about 50 kids that had a step procedure. We're up to about 150 now. This was a few years ago. So when we're doing this procedure, in general, we're doing it, kids are about a year old. I'm not a big fan of doing this under a year of age. There are some circumstances, but the majority of kids should probably try to wait until they're older, even if they are a bit dilated, because there's a lot of other things happening in that first year. And I would argue that 12 months is not a lot of time to try all the different medical things. And so you sort of want to be working at all that stuff also. So sometimes, sure, you may need to be doing this a little sooner, but I'm not a huge fan of jumping in and trying to do it at 2 months of age and 3 months of age and stuff, because in general, it tends to, I don't know, it doesn't tend to stand up as well as time passes. You know, I told you this isn't about gaining length, but you get about a 50% increase in length if you're doing it right and you're on bowel. It's about 5 centimeters dilated. Generally, it takes about 2 hours to do the operation. It's very low risk, so the blood loss is very minimal. Most kids are usually eating in about a week, and most kids are out of the hospital in about 2 weeks. And I'd say we're probably even faster. You know, it's probably a little quicker. It's more like 8 to 10 days now, because we're just, you know, time's passed and we've gotten, I think, a little bit better at managing pain control without narcotics, which helps the bowel to move quicker. So where's the money in all of this, though? Well, let me show you these next couple of figures from the paper. So these are something called Z-scores. When you guys look at growth charts, for those of you that are peds, you're often looking at growth charts with your teams. I would imagine every time you visit with them, they show you where you're at on the growth chart and what's been happening. For adults, we don't do the same thing on growth charts because you're not growing anymore. So we're just monitoring your weight. But the point of these graphs is just to show you, these graphs go from 6 months before we do the operation to 12 months after. So they cover an 18-month period. And basically they're flat lines all the way across. What does that mean? That means that a child is staying on their growth curve and they're growing just the way they're supposed to. It doesn't say that they're really big or really small or anything else. It just says they're tracking and they're following their growth curve, and which means they're growing over those 18 months just the way they're supposed to. Now, the important part comes from this next panel. The first thing, the first graph shows you enteral calories delivered. So that's calories you put into the gut. And you can see from the beginning of that to the end, it goes up. But, you know, I always argue to people, you can kind of fake that a little bit, because you can be pouring food into a baby or into an adult, eating like crazy, but pooping it all out. And so you can fool yourself to think, oh, we're doing great, look how much feeds we're on. But if you're pooping out the majority of what you're eating, then you're not necessarily gaining all that much. But if you look at the second panel shows you parenteral calories delivered. So that's TPN calories. And if you look at that, you can see by the time you get to 12 months after that step procedure, the median amount of calories, that would be like, you see the little gray box and there's a line kind of a quarter of the way up. That line represents the median, so the middle part of that population. So the median child now is getting less than 20 calories per kilogram per day, which means that's about the time when you're dropping days of TPN. So you're going from kids at the beginning who are on 70 or 80% of all of their calorie needs by TPN to maybe 10% of their needs after a year. And if you keep following them, and I've done that and have published subsequent papers to show that they actually come off more and more as time passes. So sometimes you'll hear, well, you know, you can't do it twice, you know, or it doesn't work if you do it more than one time. But here's a paper that we published last year if you do it a second time. So this was 30 kids who had to have a second procedure. In the second procedure, they're a little older, you know, a year has passed, a year and a bit, because we're watching to see how they do. Operation takes a little bit longer because there's a little more adhesion, so maybe an extra 15 or 20 minutes. Still don't lose much blood. They still get eaten in about a week, and they still get out of the hospital in about 10 days to 2 weeks or so. So it can still be done very safely. You don't gain as much length because they're normally not as dilated. But when you look at the same sort of data about how do they do over time, what you'll see is if you start off at the beginning, which is like, you know, in the 2 years leading up to the procedure, these are people who are getting, kids who are getting 75 or 80% of their calories from TPN. If you go to that final panel at the end, it says recent, you actually can't even see the little bar in it because the bar is right at the very bottom at the 0. So it means that while there are some kids who don't necessarily come off, the majority of the children will come off of TPN over time. So I'm a big believer in treating dilation. I really, really think that you can make a difference, but you have to know what you're doing. And so sometimes if you're in a place where somebody hasn't done this, the problem, just this is like an aside, but the problem with surgeons is we're all kind of a little bit egotistical. And so we all think that we can do everything. And especially an operation like this, it seems pretty easy. So you think, oh, well, you know, I can look it up in a book, or maybe I saw one once in my training and I can do this. But the devil is in the details in this procedure. You have to really be careful. You have to really be looking at the very, very minor details of how you do it. And that makes a difference between whether you have no good outcome or a really good outcome. So I think, again, this is a circumstance where, does everyone in the country need to come to me? You're all welcome to. That'd be awesome, but you don't have to. You just have to have somebody who's got experience, who you trust. And if they don't have a lot of experience, then they should call, talk to me, talk to, one of my buddies in Cincinnati or a buddy in Boston or something like that. Someone who's done this, who can say, okay, this is what you want to do. This is what you're looking for. These are the subtleties in how to do this procedure. As the field has changed, I've changed my thinking a little bit about surgery, and I'm going to touch on this a little as I go through just the next couple of sections, where I just have a few more slides actually touching on some of the newer things, and then circling back to talk about how it makes me think about managing. This is a different way of dealing with dilation. I just did this 2 days ago on a kid with pseudo obstruction. But what you're saying is, if you have a fair amount of intestine, so let's imagine you're a little kiddo, maybe you're a 2-year-old, and you've got 60 centimeters of bowel. I'm just making a number up, 50 centimeters, which I would argue is a pretty good amount of intestine in our program. Like, most kids with 50 centimeters are coming off of TPN fairly easily. So if you have 50 centimeters and maybe there's 10 or 15 of it that's pretty dilated, well, I could do a step like I just showed you. I could step that part, but 50 centimeters is pretty good. What I might want to do is actually do something called a longitudinal excisional tapering. So here you can see, instead of firing zigzag staple lines, you're sort of firing the lines in a long continuous line along the bowel. So I don't quite use the stapler anymore. I have a nicer one that I like better, but you're basically firing along, and you can see how some bowel is kind of peeling off to the side. And in the end, what we're going to do is all of this excess dilated stuff is going to be removed, and we're left with bowel that really looks back to normal. So we can gauge it right down to the normal diameter. There's a thin little staple line all the way along the bowel that within a year just kind of rolls into the bowel, and it's basically disappears. And so in an era of better TPN management and better growth factor management and these kinds of things, I'm starting to not be as concerned about saving every bit of absorptive surface, and I'm more into making sure that the bowel is shaped in the right way, that it's got just the right orientation, the right diameter, all of these little subtle things. And so there are instances where I'm actually going to sacrifice a little bit of absorptive surface. So you can see here, that outside ring of bowel, that's all gone, right? That's going to go to pathology. So you technically did lose some absorptive surface. But when you see how much bowel there is in the center of that picture, that's irrelevant. You don't need all of that big dilated bowel that's not doing jack for you. It's not helping. It's not working. You're better off to get rid of the dilation, get things back down to a more normal size, and you'll have an awesome outcome doing something like that. So what are my take homes from this first part of things? Well, dilation of the bowel can be a reason that kids can get stuck. Getting rid of the dilation can have a really big impact on how kids do. And I think that if you have a little one who was doing great, and gosh, now they're kind of stuck, their blowout poops are going up, their TPN hasn't really changed for a bunch of months. We always say here that that's the time to circle the wagons. That's when we want to do a small bowel series and a barium enema and maybe endoscopy from above and below, because we got to see what's going on. If we were making progress and now we're not making progress, something's changed, right? If you go back to that original philosophy of, if you're not going forward, you're going backwards, then that drives your decision making. So we would say, okay, if we're not going forwards, we got to figure this out. Something's wrong. And I really do believe this final point, which is the operations should be done in specialized centers by experienced surgeons. So I think there are many operations that can be done by lots of different surgeons, but there are some things where you're better off having the assistance of somebody who's done this a bunch, because things can happen that can make things irreversibly wrong on the inside. And so then you can have real problems. If people don't appreciate how to do this correctly and it doesn't get done right, not only does it not make them better, but it makes it really, really hard to fix. And a lot of what I do is fix things. And so it makes it challenging. So I'm always standing on my soapbox and going, please don't do these certain things. Please do the operation, carefully and meticulously, and make sure everything is lined up, because it's a pain in the butt if you have to fix it later. Okay, so what are some other things in the field? This applies to both children and adults. It's been more relevant in the adult side of things for quite a while, about 10 years. But there's things called intestinal growth factors. Some of you listening may be on an intestinal growth factor right now. And I'll just tell you a little bit about them and about where the field is going to go. So what are these things, first of all? Well, they're actually they're changes made to a natural protein that we all make already. That protein is called glucagon-like peptide 2, or GLP-2. And so we call these things GLP-2 analogs. And this is a protein that's made towards the end of our small intestine and in the very first part of our large intestine. And it has a control function on how the cells proliferate in the little absorptive fingers, the little villi, how the cells grow, how long those villi are, how blood flows through the intestine, probably a little bit on how the intestine squeezes. And many of the pathologies that occur that cause us to lose intestine, Crohn's disease, or in little kids, gastroschisis, necrotizing enterocolitis, we often lose that ileum and we lose our GLP-2 producing part of the intestine. So in effect, what you're doing with growth factors is you're giving back something that you've lost. So right now, the one drug that's approved for us is a drug called teduglutide. The trade name is Gattex. And this has been approved in adults for about 10 years or so now, maybe a little bit more than that, actually. It's been approved in kids since I think about 2019, after we did the PD trials, like 2016 to 2019. And what it does, it's a little injection. It has to be mixed up each day and given as a little shot. Generally, it's tolerated very well. And it leads to a growth of the lining of the intestine. So it doesn't make the bowel longer. If you have 1 foot, it doesn't give you 2 feet, but it makes that 1 foot work more efficiently. And so the shots are usually pretty well tolerated. It's a very small needle. And, we've got maybe 35 or 36 kids on the drug right now. We really haven't found, after kids, no kid likes a needle, but once they realize it's not as bad as they think, they actually tend to tolerate it very well. Some parents can do it while the kids are asleep and they don't even wake up. And in general, it does lead to a reduction in intravenous support in most of the children treated with it. That's what the studies showed. Does that mean everyone who goes on it automatically comes off of TPN? Well, not necessarily. But if it's used in the right circumstances where you've optimized everything else and you fix whatever has to be fixed surgically and then you use it, you can get really good outcomes. And we've had lots and lots of, it's changed for us how we think about managing short bowel, because now the lengths of intestine that we can get off of TPN have gotten shorter and shorter and shorter. Now we're talking about adults who have 30 or 40 centimeters of small intestine and a decent amount of colon coming off of TPN fairly routinely. People who have adults with 100 centimeters of bowel to an ostomy coming off of TPN, maybe still on some IV fluids, but these are things that were unheard of 10 years ago. And on the little kids, now we're starting to talk about kids with, 10 centimeters of bowel, 8 centimeters of bowel, 6 centimeters of bowel, who have a realistic shot at coming off over time as they adapt. There's a few other reasons why that can occur that we'll get into when we get into the next slide after this, but what's coming up in the pipeline? Well, so on the adult side of things, we've been doing adult trials on the next generation of drugs. They're the same peptide, but just modified so that instead of having to be given daily, it can be given weekly. And what we're seeing, we're finishing up the first trial, so the data is not unblinded yet. But we always kind of guess at what our patients might be getting. We don't know, but it certainly seems that the new drugs are working very well. The patients seem to be tolerating them well, and they seem to be doing well with these once weeklies instead of doing them once dailies. So I have a feeling that the field will likely go in that direction. We'll likely get to a time where these drugs, if you are on them or you have a child who's on them right now and you're doing dailies right now, you're probably going to get to a point where you're going to switch to weeklies. The PD trials are probably going to start in about 18 months to 2 years or so. Just depends a little bit on how the data looks on the initial trials and what the FDA has to say. But I think these things are changing the whole calculation of who you operate on and what sorts of things you operate on. Some of the panelists, we were just chatting a little bit before we started the talk today about there's certain conditions that we treat now, say in adults or even in kids, some of the pseudo obstructions, conditions where the bowel doesn't seem to be functioning forwards well, and we don't always know why. There's all kinds of different things. There's problems with muscle cells, muscle proteins, nerves, scleroderma, where you get sort of thickening of the bowel with scarring and fibrosis. And because we always used to think we have to save every bit of bowel because we don't want to have short bowel syndrome, we would end up, poor patients would have, 20 feet of this stuff that's not working very well. But I've just spent the last half an hour telling you guys, gee, we're really good at managing short bowel patients, and we can get most short bowel patients off of TPN. So it changes the way we think, because now you say, well, gee, maybe instead of keeping 20 feet of bowel that's not working really good, why don't we just give you 6 feet of bowel or 3 feet of bowel? Because if it's still not going to be working really good, at least there's less of it not working really good, which actually tends to give you a nice balance with forward flow. And if you can find the sweet spot, and it does take a little bit of figuring out sometimes, and it's why you want to have a really good, tight relationship with your patients. But if you have that tight connection where you can say, look, we're in this together, we can get you through this, but we're going to have to figure your insides out of it because we're breaking new ground. But in some cases, I really think philosophically now, in the major centers, when I'm sitting around talking with my compatriots in the other big places, we're sort of saying, gee, maybe we should be shortening people, because when we do that, we seem to get really, really good outcomes, and we can manage the shortness. So that's just one way that medications are changing how we think about surgery. What's one last thing that I think is going to be, I think this is going to be a huge impact. This is unfortunate because we're behind the times in the United States compared to other countries. But many of you, everyone who's got a line is probably going to be familiar with locks. So you might be on a heparin lock or an antibiotic lock, or maybe you've been on ethanol locks in the past. We've gone through a whole adventure with those where we started doing 70% locks, and then we went to 30% locks, and then the government changed some wording in one of our laws, and suddenly a lock went from being $40 a day to being $1,000 a day, so then we all lost them. Well, there's a couple of different locks now that are available in other places in the world that are having big impacts, and we just don't really have them yet in the United States. Boston has a clinical trial that's ongoing right now, so it's one place where you can access them. We're going to try to do the same thing here. But this is some data that just came out a little while ago from Toronto, from Sick Kids in Toronto. It's a small study, but I wrote a little editorial about this for one of our major journals, sort of talking about how this is a small study that's going to have a huge impact. So the locks they used in these are called 4% EDTA locks, and that's a chemical that binds up calcium, it binds up metallic ions. And so calcium is needed for life. Every organism needs calcium. And for blood to clot, there has to be calcium. So you could take a little bit of this 4% solution, put it into the line, flush the line, just like a milliliter or something. If a teeny little bit gets out of the line and goes into your body, it's not enough. It doesn't do anything to your calcium levels. It's an insignificant amount compared to your body, but it's a really important amount compared to your line. So it strips all the calcium out of the line, which means bacteria can't live and blood can't clot. So you cut down on your line occlusions and you reduce your infections. So in this study that was done by Paul Wales's group, they went from 2.7 infections. When we talk about infections in papers, we talk about per 1,000 catheter days. So if you think 365 days a year, say 3 kids with a line in would be roughly 1,000. In 1 year would be roughly 1,000 catheter days. 3 times 365, that's like 1,200, but it's in the ballpark. So in an average program who's doing ethanol locks and antibiotic locks and all that kind of stuff, we all get kind of around 2 to 3 infections per 1,000 catheter days. So if you talk about those 3 kids, I told you 3 kids following for 1 year, roughly each kid is going to have about 1 line infection per year. But when they put them on EDTA locks, they had no infections at all in a year. Their median was 0. And so this is a relatively minor intervention. It's got no real morbidity. It doesn't cause any problems. But look what's happening. Like, not only are you seeing no infections, but their need to do like TPA for the lines, clots in the lines and stuff, dropped dramatically. And so in the editorial that I wrote, I said, look at this. Like, this is 20 kids worth of data that's going to change how we all want to do things. Because if you can get rid of people having clots from their lines and get rid of line infections, all of a sudden, that gives you the ability to take a little one who might be 6 months old or 1 year old or 2 years old. And 15 years ago, we would be like, oh my gosh, transplant's the only thing we're going to be able to do. But now we can say, you know what? We're pretty good at managing TPN. You guys are going to hear about like alternate lipids and stuff later on. Game changers, like these are game changers that have been going on for a decade now, right? Maybe more than that, actually, more like 15 years. Change the field. And so we can manage TPN chronically with very low morbidity. And now if we can eliminate line complications, well, suddenly we can take these little kids and we can say, you know what, you may have to be on TPN for a long time, but we know your bowel is going to grow in proportion to your body, just like your arm grows in proportion to your body, your intestines grow. So that third trimester, you get about a doubling of intestine. Between your first year and your second, or birth, I should say, in about your second to third year, you get kind of about another doubling or so. And then by the time you get to be about 12, you get about another doubling. So that little tiny piece that someone tells you your baby has, they say, well, there's only 10 centimeters of intestine at 27 weeks of gestation, suddenly becomes 50 centimeters of intestine by the time you're 12 years old. And I told you guys a little while ago that most adults with 50 centimeters are coming off of TPN. So this is starting to change the way we think about managing children, because we can actually take the long game in some cases. And we can say, we know your calorie needs are really high when you're a baby or you're a toddler or a teenager in puberty, right? You need a ton of calories to grow, build new bones, build new muscles, develop, go through all that kind of stuff. But once you finish growing, so in girls, kind of 15 to 16, for boys, maybe 18 or 19, short bowel kids tend to be just a teeny bit delayed. But once you stop growing, your calorie needs drop dramatically. So a baby might need 90 calories per kilogram per day. So if you took 90 calories per kilo per day, if there's any adults that are, or all the adults that are listening, everyone who's listening, if you weigh 70 kilograms, which is like what, 140, 160 pounds or so. So if you weighed 70 kilograms and I was trying to feed you like I fed a baby, you would have to eat 6,000 or 7,000 calories a day. Right? So, and that's what you need, but you don't need that. What you need at 70 kilos is probably 1,800. So you need somewhere around 25 calories per kilo per day. So now if I'm sitting down and I'm talking to having a clinic visit, meeting with one of my short bowel kids and with their families, and I might be saying, well, gee, you're not off TPN yet, but I can tell, because I know you need 70 calories per kilo to grow, and you're growing beautifully, and I'm only giving you 30 calories per kilo. That means you must be absorbing 40 calories per kilo. And I already know if you're absorbing 40 calories per kilo now at the age of 2 or 3 years old, if I can do nothing else but keep you healthy, you're going to, quotes, outgrow your short bowel syndrome. And so this provides us with an incredible amount of hope as we look forwards, because we say, you know what, now we don't necessarily have to be under the gun the way we were when I was a trainee, and kids would come to us 6 months of age on death's door, and all we could do was race to get organs and try to transplant them, and half of the time they would live and half of the time they wouldn't, and it was just heartbreaking for us. Now we don't have to do that. We can sort of chill, and we can go, yeah, let's take some time. Let's do a surgery to correct things. Let's optimize diet, and let's do all these different things, and we can maybe achieve things by taking the long view that this might take us a few years, but we can get there safely. So I will wrap up with this last slide, and then I'll be open to questions. I haven't looked at the chat function yet, but I'll look at it in a second. So I really believe if you're not going forward, you're going backwards. And it sounds silly, it sounds simplistic, but this drives all the decision making. If you're always trying to make progress, then what you have to do kind of falls in front of you. You can see where the next step is. I think you need to talk early with specialized centers. So I really think it's important. It doesn't mean you have to go. You don't have to leave your state or anything, but I think it doesn't hurt to hear what other people have to think, especially people who are doing this all the time. Or maybe you have a team locally that you really, really like. There's nothing wrong with going to a bigger center once a year and just saying, hey, here's what we've been doing. What do you think about things? And then we get to know you, and we can talk to your team, and we can say, hey, you might want to try all of these different things. I think you want to restore continuity early. So I'm a big, big fan of this. And part of this is something I touched on a bit, but maybe I didn't stress enough in this talk, is you have to get eating early. It's so important. Again, it just drives me insane when kids show up at a year or 16 months or 18 months, and they've never been allowed to eat, because we all take eating for granted, but if nobody ever lets you do it, you don't know why. You don't understand it. The sensations feel weird. You have this oral aversion. You don't want to eat. And man, talk about a tough thing to battle when you get into kindergarten and into grade school and everything else. So it's something we really, really harp on. And we work so hard to try to get oral intake going as early as possible, irrespective of anatomy. I don't care what anatomy you have. Every child should be taking some stuff by mouth. There is not a kid. You could have your stomach stapled off and you should be taking something by mouth because you do not want to lose that skill. Knowing when or not to operate is really the most important thing. So I showed you some different pictures of me doing surgeries and stuff, but it's not, there is a lot of devil in the details in the surgery, but knowing when to do it is probably the most important thing. And as a parent or as a patient, it's that feeling that, okay, we're in this together, that you understand me, you've heard what I have to say, I feel comfortable with you, and now it's time to go on to this next step. That's where you want that experienced person that you have a good relationship with. And finally, the things that I wrapped up the talk with, growth factors and these new line locks are changing outcomes and they're changing decision making. So they're turning an acute, stressful, have to do something right now problem into something that says, no, I can let nature take some time. I can let some years pass and let you grow. And we can give you a great quality of life. You know, we've got now of our early generation kids are all getting into high school and finishing high school and going off to college. And we never had kids in high school and in college with short bowel syndrome. That just wasn't a thing. If you went back to, you know, when I started doing this in the early 2000s, you know, 20 years ago, there weren't short bowel teenagers, so very few, because unfortunately we just didn't have the ability to keep people alive, and they either got transplanted or they didn't make it. But it's different now. We don't have that anymore. Now we have short bowel grade schoolers, we have short bowel high schoolers, we have short bowel college students, and I can tell you they do great, whether they're on TPN or not on TPN. We can give them a very, very normal, very good quality of life, and in a high percentage of patients we can get them off of TPN. So I think in our field, the future has never been brighter. I've never been more excited to be doing intestinal failure than in my life. And I know that that's what everybody else thinks when we're at meetings. You know, we have, if you have a little one right now with short bowel syndrome, it's the best time in history to have to have a difficult diagnosis, because the things that we're going to get in the next few years are tools. The growth factors are going to get better. The operations are getting slicker. The TPN management is getting better. And I've never felt more positive about what the future holds. So I will wrap up there. This is my my email. If anybody wants to scribble it down, that number there, the 402-559-5000, that's our program number. So if you just want to call because you want to get in touch with one of the nurses to talk things over, or get in touch with me or something, that's the best way to do it. And I will jump up to the chat function here. And I see there's some stuff on chat and some stuff on question and answer. So I'm going to click on my chat, and I am going to see, and I will go through the questions. Okay. So I will look at, so my first one, the first question I see is from Gabriella, and it says, my son had gastroschisis, which I was told the intestines are healing due to being exposed to amniotic fluid in utero. My understanding was stretching damaged bowel wouldn't make a difference since it was damaged and needs time to heal. Dr. Mercer, what are your thoughts on STEP for gastroschisis short bowel kids? Okay, so this is a good question that lots of my compatriots talk about. In general, when we're managing kids with gastroschisis, there tends to be, there's a slight propensity for their motility to be not as good, but it's not a night and day difference. It doesn't mean that every kid with gastroschisis can never be successful, or that they're way harder. They just, sometimes they're a little bit pukier, a little bit harder to manage forward, but it's not night and day different. We've analyzed our data on doing step procedures, both primary steps and secondary steps, and we have found no impact on the underlying cause of the short bowel syndrome as to how kids do afterwards. So we would do a step procedure on a child with gastroschisis if they were dilated. Absolutely, I would. And my simple argument, back in very simplistic terms, would be, okay, well, if your bowel is really, really dilated and it's not working forward and you're not able to tolerate any feeds, or you're just stuck on, 5 mils an hour, or something that's, hardly worth doing, then, if you fall back on, if you're not going forward, you're going backwards, I would argue, well, you're not going forward, so you're going backwards, so you should do something. Now, does it have to be a step procedure? Well, if you have enough bowel, maybe a gastroschisis kid will do better with that tapering, that longitudinal tapering. But I think that I think that it's important to do something. And our data, this isn't just me sort of waving my hands and talking loudly. The data says it doesn't make a difference as to whether you have gastroschisis or other causes. So I think if you have dilation and it's causing you problems, I think it's something worth thinking about. Carol asked a question saying, can you say what the top 10 intestinal rehab centers are or where we can find that data? This is a tough one. Because politically it's tough for me to say what the top centers are. And honestly, I don't mean to be evasive about this, but I am being a little bit evasive about it. Obviously, I'm giving you the talk, so I'm going to tell you Nebraska is a pretty good place to be. And I mentioned a couple of other centers, but this is tough, you guys. In pediatrics, there are a number of centers around the country. Most states have a center. That having been said, just because you say that you have an intestinal rehabilitation program doesn't necessarily mean you do a lot of intestinal rehabilitation. And it's worth looking into that a little bit. I'm not trying to subvert anybody, but if you say you have a program specializing in intestinal failure and you have 4 kids with intestinal failure, well, you maybe don't have that much experience. And maybe that's a center where you could be there and you have really engaged great people who will help to look after you. But maybe you tie into somebody who's looking after 300 or 400 kids with short bowel syndrome. And so I think that's it's a tough thing. It's a tough thing for parents. It's a tough thing for patients. If you think it's tough in pediatrics, it's way tougher in adults because there are like a handful of adult centers across the country. In some places you're seeing pediatric people actually doing adults because there's so few people who have developed a program to treat adults. And so in those cases, I mean, we're one of them, right? We're right in the middle of the country. Omaha's right smack in the center of the map, but there's really not much in the way of dedicated adult intestinal failure west of us. There are some good centers, individual places, but it's tough. So there isn't data. I'm doing a paper right now with some collaborators from around the country looking at this massive database of all the prescriptions for TPN in the whole country to try to figure out where people are, how far they are away from centers, what's happening nationally. But right now there isn't any data. There isn't a central repository. You tend to find out by asking, by going online and talking to other patients and saying, what have you heard or where are you at? Maybe you can find somebody who's reasonably close by, but it is tough. A better thing for this would be honestly, if somebody, we have that 559-5000 number, the 402-559-5000. If people want to call that, we're not just going to give you the hard sell of, oh, come to Nebraska. If you are in, North Carolina or wherever the heck you are, California or Alaska or something, what we're going to do is say, hey, you can come here if you want, but here's some other thoughts of places that might be close by. Let's look. Oh, Gabriella had another question then, maybe in response to what I was saying. Do you keep data of failed step rates where it doesn't make a difference? Is this information public? So there's not a good national registry for this. There's been some attempts over the years to do it, but it didn't really work out that well. Centers weren't contributing to some of the databases. So what I can tell you is, so in our own data, this is all published. So those papers that I showed you, you can pull up those papers and they have the rates of, they show who it doesn't work on. If you do a first step procedure on kids, about 35% of the kids will have to have it more than once. I showed you the data to say if you do it more than once, the majority of the kids are still going to come off of TPN, but I will tell you, there are some children who don't seem to have any benefit from having the step procedure. And I have tried to figure out how to predict that, but I can't figure out. There doesn't seem to be anything that I can tell from looking at the data to say, oh, it's always this exact kind of kid or it's this kind of diagnosis. I told you in my answer earlier about gastroschisis that etiology doesn't seem to make a difference. Because if I look at the kids that aren't successful, it isn't just gastroschisis kids, it's distributed. The problem is when you're trying to do these analyses and looking at your own data, and there's maybe 150 cases, and if you try to do these fancy multivariate analyses to figure out who's failing, the numbers get so small that the statistics don't work out. So there isn't really a public repository where you can say, what's the national rates of failure or something, but you can certainly, you can look at our data and everything, we've got it all right in there, or call and talk to us and we'll let you know. But the majority of the kids are really having, it's a small minority, like maybe of 150 kids we've done steps on, kids who have had absolutely no improvement, a handful, less than 10 that have never had any improvement. And I'll tell you, in general, for us, where we see a difficulty getting improvement is kids who have been left dilated for years and years and years. So they show up, they get sent to us when they're 10 years old or 12 years old, and they've really not eaten much for the last 6 or 7 years. They've been dilated the whole time and nobody did anything. And if you try to do something to them, it can be more challenging to get that bowel to work again. It's not so bad if you get them when they're 2 or 3 or 4 years old. It's still better to get them sooner. I would love to see the kids quicker, but if they're older and they've had a lot of years where nothing has been done, that can sometimes be more challenging. Let me just roll down the questions here. Where's my cursor? Okay, that's the end of the chat function. I'm going to click on the Q&A part.
Yeah, Dr. Mercer,
Yeah.
Rebecca Arandella asked, are the kite locks approved in the US yet? And I'm interested, so tell us.
So kite locks are not approved yet. And that's what I was saying, we're behind the times. So the only way that we can get them right now, and we're just going to try to get on this here as well, because we, as the data came out, we were like, wow, okay, that does look pretty cool. Basically what you have to do is kind of like what we did for any of you that know what Omegaven is. The fish oil lipid that you may or may not have been on, depending on how old your kid is. When we had to get Omegaven to people before it was approved, what we had to do was sort of make up clinical trials and use the clinical trials as a way to get access to the drug. That's what Boston has done. And you can get them sort of as a one-off. You can get compassionate release here and there, but it's a laborious way to get access to it. So we're going to try to follow what they've done and just put together a clinical trial. I don't think it will take us too long to be able to do that. The company is very receptive to trying to get it to as many people as they can while we work to try to get it approved. But the way the FDA works, it takes a while to get approval. But your point there about the charging, really, this is like a pennies per day intervention. That's like a game changer. So Rebecca's point is like we totally should be able to use it, and it would make a big difference to us, I think, as a field. And I see one more question here. It just from Robin. It says, can you comment on the use of Gattex in early intestinal transplant failure? Is there any data? So there isn't, Robin. There's no published data. I don't even know. I'm trying to think of if there's even a case report. There could be. For some reason, I feel like there might be, and maybe I just haven't read it. But I think somebody might have. We've thought about it a little bit. So if you've had a graft, it depends on the reason for the failure. So if you've had a bad exfoliative rejection, the bad ones, these are the ones where all the lining of the bowel was lost. It depends a little bit on if you've maintained any of the stem cells in the gut as to whether it would even have the ability to work or not. And sometimes in chronic rejection, so in someone who's had an intestine transplant for a long time, and you go in and you take biopsies and it looks really good, but yet you're back on TPN because it's not absorbing very well. The challenge there is that sometimes the reason you're not absorbing is actually deeper than the villi. It relates to how lymph flows and how blood flows, and scarring that comes in blood vessels. And so there, making the villi longer might not necessarily impact, because the problem isn't so much absorptive surface as it's what's happening deeper. So, but I've definitely wanted to. It just hasn't come up for us yet. It hasn't come up at a time. I had an adult patient who I really thought it would have worked on. She just declined to. She just didn't want to be bothered, and didn't want to do the injections. She was just happy to not bother doing it, so we didn't. But I think some of my other compatriots are thinking about doing it also. So,
excellent. Well, I want to thank you for sharing your Saturday with us.
No problem.
And I thought that was a fabulous presentation. I know our attendees will love it as well. The ones that are here have already enjoyed it, and then we will have this online for those that didn't get to come today. So thank you very much. go enjoy your Saturday, please.
Thank you very much. Bye, everybody.